And thank you all for taking the time to join us today for the IFA's weekly Global Café. I have the distinct pleasure this morning of being your moderator and in being in conversation with Dr. Vivien Brown. In addition to her work as a family physician, Dr. Brown serves as an assistant professor in the Faculty of Medicine at the University of Toronto. She is also an author, pioneer, and tireless advocate for raising awareness about women's health issues, preventative healthcare, and healthy aging. She is an internationally recognized leader in her field, and in 2023 was named among the top 25 influential women in Canada. Dr. Brown continues to work to help shape policy in Canada through numerous advisory bodies, including Immunize Canada, where she helps to ensure immunization as a part of healthy aging is prioritized. While Dr. Brown's expertise is wide-ranging, we have the opportunity today to take a closer look at herpes zoster, better known as shingles, an important vaccine-preventable disease that can have devastating impacts on older adults. Dr. Brown, thank you so much for joining us today.
Thank you, Anna. It's a pleasure to be here.
Fantastic. I thought to kick off our discussion today, I'd love to start with a little bit of your own journey. As a family physician, I'd love to know what sparked your interest in healthy aging and how immunization specifically became a key area of interest for you.
Well, you know, in family medicine, we're putting out a lot of forest fires. We're often seeing a disease and jumping in and trying to modify that disease by adding in medications or testing or whatever. What immunization is all about is preventing that disease in the first place. And, you know, we've all grown up with the adage, an ounce of prevention is worth a pound of cure. And it is so true. Preventing a disease is incredibly satisfying, but actually has very poor PR, right? There's very poor understanding of what you've accomplished when you prevent a disease. There's no headlines. You know, we don't celebrate the fact that we've prevented so many cases of, you know, whatever disease it is. But for the individual, it makes such a huge difference. So whether we're talking about shingles or talking about pneumonia, whether we're talking about HPV and various cancers, the whole concept of keeping people healthy, keeping people independent is what vaccination is all about. And I'll go one step further. You know, in adult vaccination, and think about flu as an example, we don't necessarily eliminate every episode of the disease. We attenuate the disease or we decrease its severity. So for example, with flu, when we give flu shots to everybody, they may still get the flu. You may still be at home for a couple of days sick, but you're not going to end up in the hospital. You're not going to end up on a ventilator. You're not going to die of influenza. So I think when our expectations about vaccine are appropriate and we vaccinate for all these vaccine preventable diseases, we keep people independent. We keep people in the community. We keep people healthy. And that's what it's all about.
Thanks so much, Dr. Brown, and touched on that wonderful public health paradox that we all deal with. I'd love to know a little bit about, you know, from your perspective, why immunization is important for older adults specifically, and what puts older adults at increased risk for negative health outcomes.
Yeah. Well, you know, think of the other parts of your body and how they age. And I'll use our vision. I'm wearing glasses. Some of you are wearing glasses. As we get older, our body ages and we're not as sharp as we were when we were younger. Well, your immune system is the same. Your immune system ages with time. And because of that, it doesn't fight off diseases and infections as well. And so what we know is that by immunizing, and again, I'll use flu as the example, flu shots for people over 65 are higher dose. By using a higher dose flu shot, you get a better response by your immune system. So what we really want to do is we want to boost our immune system to fight off these diseases.
Fantastic. Thanks very much, Vivien. So now the focus of today's discussion is really around shingles. And I thought before we kind of get into some of the deep questions around shingles, can you provide us a little bit of an overview as to what shingles is, herpes zoster, and what are some of the kind of symptoms that people are looking out for, and more importantly, some of the symptoms, early signs that are often missed?
Yeah. It's a good question, Anna, and I think, you know, we all need to understand this. When we're younger, we get chickenpox as a disease. That is called the varicella virus. Our bodies fight off the varicella virus. We get cured from chickenpox, but that virus still lives in our system and our immune system suppresses that virus. It's latent, it's parked away, but it's not eradicated, it's not gone. And so what happens with aging primarily, as well as with immunosuppression and some other diseases, but what happens over time is that we're no longer able to suppress that varicella virus. And the varicella virus breaks through, comes to the skin, comes to the surface, and generally causes a blistering rash in one area served by one nerve. Typically, it's on the face or on the trunk. And an area served by a nerve in terms of skin is called a dermatome. So one dermatome is affected and you get a blistering rash. That blistering rash is called shingles or herpes zoster. So it's your own body no longer suppressing the virus that allows the virus to come to the surface. And that's where we get shingles. It causes a lot of nerve irritation and it causes the rash. Now the rash can heal and go away, but the nerve can be left very irritated. And so when you have chronic nerve pain after an episode of shingles, it's called post-herpetic neuralgia. The nerve is still damaged. And unfortunately, the older you are, the more at risk you are for PHN or post-herpetic neuralgia. So the whole thinking about the vaccine was not so much to prevent the rash, a few blisters, it'll get better, but to prevent the chronic pain that some people have from the virus damaging the nerve.
Understood. Thanks so much, Vivien. Another question, shingles is actually quite common, but the awareness is really low and prioritization for it as a vaccine preventable disease seems fairly low. Can you speak a little bit as to why that might be the case?
Well, shingles is very common. If you live till you're 80, the Canadian statistics suggest that your chance of getting shingles is 50-50. 1 in 2 Canadians will have shingles by the time they're 80. The older you are, the more at risk you are because your immune system is getting weaker. Women are more at risk than men, and Caucasian women are more at risk than other women. So there's a number of risk factors, but age is the #1 risk factor. We also know that if your immune system is compromised, if you have another disease that affects your immune system, like psoriasis or MS or lupus or rheumatoid arthritis, those diseases affect your immune system, you're more at risk for shingles. And if you're on certain medications for inflammatory bowel disease, psoriasis, any of the immune modulating medications, again, you're more at risk for shingles because your immune system is basically suppressed. So it's very common in the general population.
It's good to know. I think when I first started learning about shingles, it surprised me so much of how high the rate was, considering how low the awareness was. So I think it's so important that people are aware of that. One of the questions I had, I know, Vivien, that you're also an expert in women's health. Can you speak a little bit about, or kind of unpack a little bit about that gendered aspect of it? Why is it that women are disproportionately affected?
Yeah, Anna, it's a really good question, and we don't really know the answer to that. There must be some kind of hormonal basis, but I can't answer that because there's no clear data on why women are more at risk. But certain families are more at risk. If your mother had shingles and your father had shingles, so 2 first-degree relatives, your risk is higher as well. And so I think we need to think of aging as the #1 issue, because after age 50 in every country in the world, shingles goes up. Doesn't mean a younger person can't get shingles, but it's less common and they're less likely to get the complications of shingles. So they're less likely to get post-herpetic neuralgia. But with time, your risk goes up to be 50%. What's also interesting is other diseases like diabetes and COPD and cardiovascular disease also increase your risk of shingles. And that's partly because they're affecting your immune system as well.
Interesting. Thanks so much, Vivien. You talked a little bit earlier about the idea that expectation around vaccination and the efficacy of vaccination, this idea that it's, I think there's a mentality, and certainly we saw this through COVID, where it's this all or nothing. I take the vaccine and I shouldn't get the virus or whatever you're looking to prevent. I see that as a bit of an impediment to kind of motivating people to get vaccinated. I'm curious as to kind of how you see that as a role or in motivation, and what other barriers and factors you see in kind of preventing people from getting vaccinated.
So in general terms, I think vaccination is all about independence. I don't want to visit you in the emergency. I don't take care of you once you're in a nursing home. I am a community-based family doctor, and I want to keep you in my practice. In order to keep you in my practice, you need to be in the community. You need to be in your own independent living. You need to be in your own home, condo, apartment, whatever. So when we look at vaccine, whether we're looking at pneumonia vaccine, flu vaccine, shingles vaccine, it's all about keeping you healthy enough to stay independent. Now, the shingles vaccine is particularly potent and has a particularly good data about preventing the disease. The younger you are when you take it, the better it works. But even if you're over 80, there was about a 90% efficacy rate, which means only a small number of people still got shingles after they were immunized. And if you do get shingles, it tends to be a milder case. So when we talk about vaccine, we need to be clear. It may not eradicate the disease. It may not prevent every episode of the disease, but it prevents the severity of the disease. So you're not likely to get hospitalized. You're not likely to be in the ICU. You're not likely to need a ventilator. So when I present this to patients in my practice, it's all about keeping you in the community, keeping you healthy. And with influenza, as an example, if you get the flu for a couple of days and you're home, okay. But if you get the flu and you're ending up on a ventilator in the ICU, it's not okay. And that's the difference immunization makes. You may still get the disease, although less likely with shingles. You may still get whatever disease we're trying to prevent, and think about pneumonia, flu, those kinds of diseases, but you're not likely to die of these diseases. This is all about modulating the effect of the disease by having your immune system prepared and responding to whatever you've been exposed to.
Thanks so much, Vivien. Now, you've talked about your role as a care provider, and I wonder whether you can kind of touch on the importance of kind of care pathways in both raising awareness around immunization, but also access to immunization.
So first of all, congratulations on holding a seminar such as this, because I think it's really important that people understand immunization, whether we're talking about pneumonia, whether we're talking about flu. Coming up in the next 6 to 12 months, we're going to be talking about RSV vaccine, which is respiratory syncytial vaccine. Really important. Looks like flu, acts like flu, but it's not flu, and it's a separate immunization. And I won't even begin to say how important it was to get immunized for COVID. We all understood that very quickly, because if you were immunized and you got COVID, you're home for 5 to 7 days. If you weren't immunized, you're in hospital and you can't catch your breath. And unfortunately, we had a significant number of deaths from COVID. The reality is, when we look at the care path in Canada, basically shingles has been approved for everybody over the age of 50 in every province and territory. It is also approved for age 18 to 50 if you're immunocompromised. So if you're one of those people on one of those drugs or with one of those diseases, you should be getting a shingle shot, even if you're 30 or 40, because your immune system is not robust. Different provinces implement guidelines differently. And so in Ontario, shingles is paid for if you're between 65 and 70. And right now, and this audience should know, even if you're up to age 73 in Ontario, because of COVID and the delays with vaccination, Ontario will pay for shingles. PEI will pay for shingles for everybody over age 60. Other provinces have not yet decided or put money towards the shingles prevention program. So depending on where you live, you may have access through your family doctor, through your pharmacy, and it may be covered for you if you're in the right age group in the right province. It takes a long time for all the provinces to cover everybody because budgets are different in every province.
Absolutely, Vivien. Thanks so much for that. I want to turn to some of the questions we have populating the chat because they're already coming in. I think you've touched on Francis's question, which was really about kind of payment of around the vaccine and the cost. But I want to go to Shmuel, who's with us every week. And he's asking a question here about what can you say about the risk and impact of shingles among older adults in a kind of, for those that are kind of low or low income or low socioeconomic status?
So when I talk about vaccine and I talk about the cost of vaccine, I also talk about the cost of not being vaccinated. Because when you choose not to be vaccinated, you're playing Russian roulette, if I can use that term. You're taking chances with your health. And what happens with shingles is you sometimes can get a bad case with chronic nerve pain, be on multiple medications for pain for 3 months, 6 months, 1 year, 2 years, 3 years. People are miserable with post-herpetic neuralgia. And so it's 2 shots to take the shingle shots. And I think it's really important. And when I talk to people who are thinking about it and not sure they want to spend their disposable income on vaccine, I think you have to really think through the cost of not being vaccinated and the chances that you're taking.
Absolutely, Vivien. Thanks so much for that.
The other thing, Anna, is you don't have to buy both shots at once. You take the first shot, and the second shot ideally is between 2 and 6 months. But with COVID, we got permission to wait as long as 12 months for the second shot if necessary. So while I encourage people to take the second shot within the 2 to 6 months, if you can't afford it and you're saving for this, you can wait as long as 12 months and still get a good response to the vaccine.
Thanks so much, Vivien. I want to kind of just dovetail off this because I think it's a really important discussion, this idea of kind of cost benefit and how that's assessed by the government. I'm wondering if you can speak a little bit to kind of the role of kind of surveillance, monitoring, and data. We know that data on older adults is sparse at best most of the time. So wondering whether you see that as kind of a key factor or what we can be doing to kind of better prioritize this at a policy level.
So the government often makes decisions about vaccine based on hospitalizations and deaths. So for example, with COVID, there were so many hospitalizations, so many deaths, no question this vaccine had to be available for everybody right away. And we tried to get the population immunized quickly. With shingles, you don't see a lot of hospitalizations and you don't see a lot of deaths. You see a lot of misery and people are very uncomfortable, and we're using a lot of pain medication, and those pain medications have side effects and people are groggy and they slip and they fall and they break their hip, and there's a downward spiral when you have a bad case of shingles. But from the government's point of view, it's hard to measure exactly what is an effect of shingles, the disease, what is effect of medication, maybe medication misuse, and the various complications from medications. My own feeling is that vaccine is probably less than 4% of the public health budget. Public health does not spend a lot on vaccine, and we need to encourage public health to spend more. And I think older people over the age of 50 are a huge voting bloc. And we know through AARP and CARP and some of the organizations around retired people that when retired people speak about something, the government often listens. And one of the examples is the availability of the high-dose vaccine for older people in flu. And so I think this is an area where advocacy would be helpful. And why Ontario picked age 65 to 70 to cover is because it's cost effective. By immunizing this group, they're going to live long enough to pay off the government in terms of not using other facilities and other resources. So I would say that advocacy is really important. And that is something that everybody can take part of by speaking to your local MPP or by being part of a group. And certainly the lung groups, the Asthma Society, the Lung Society, they have a voice and they often speak out about their diseases and the vaccines involved for those diseases. I will just say, for those of you that are in Ontario, if you're as old as 73, you're still eligible for vaccine for shingles this year. The age group is 65 to 70, but we're behind by 3 years because of COVID. So until December, you can get shingles vaccine paid for by public health up until age 73. At the end of December, that is likely going to change. So if you happen to be in that age group, or you have family in that age group, tell them to see their doctor now, because it's July. You've got enough time to get the first vaccine and the second vaccine before the end of December, and it may be covered for that individual.
Thanks so much, Vivien. Very helpful information for our folks from Ontario here. There's a great question here from Brendan Sherlock. Brendan, would you like to come forward and ask your question?
Yeah, it's I don't think here in Ireland the vaccine is available. I know I've had shingles and I certainly haven't been offered the vaccine. And the other thing is, you're quite right about the pain involved in shingles. It can be quite debilitating. I just, while you were speaking, I just thought of being placed in a bath with a bath full of jellyfish who are voracious in their task of stinging you, and that's what it's like. Thank you.
Well, thank you, Brendan, for sharing your personal story, because post-herpetic neuralgia, that nerve pain, can be so terrible that there have been suicides over the chronic pain because people could not live with that pain. I'm not sure whether Ireland has Shingrix approved or not, but in North America, it is approved, and it is approved even if you've had shingles before, because having had shingles once doesn't protect you from getting it again. So even if you've had shingles, you should be immunized. And even if you've had an earlier vaccine, which was out in 2013 to 2017 called Zostavax, you're still advised to get the newer vaccine, which is called Shingrix. And that's because Zostavax was a live virus vaccine. It wears out with time, where Shingrix is a stronger vaccine and is more long lasting.
Thanks very much, Vivien. I think you hit on a great point there, which is the idea that we can still be vaccinated after we've had shingles, and the importance of that. I want to touch a little bit. There's a great question here from Cynthia, and those sentiments are really echoed by Shmuel as well. Cynthia, would you like to come forward and ask your question?
Sure, thank you. I'm really curious, and maybe just wear your family physician hat and all vaccines. How do you deal with people, whether they're parents or adult, older adult age, who are anti-vax?
Yeah, so that's a really good question, Cynthia. And what I would say is, statistically, there's a lot of people that are vaccine hesitant. Vaccine hesitant says, I'm not sure, do I really need this? Why do you think I need this vaccine? That's different than someone that is anti-vaccine. Don't talk to me about it. I'm never going to take anything. There's only, in Canada, there's only about 2 to 3% that are actually anti-vax, where there's a large number that are vaccine hesitant. So if someone is vaccine hesitant, the guidelines suggest, and the data suggests from research, that more than 80% are open to education. So for example, with shingles, I'll talk about how afraid I am of this disease. I'll discuss the fact that I have a patient who got a bad episode of shingles. It was over his face, went into his brain. He ended up in the ICU. He ended up, unfortunately, having cognitive impairment from shingles being in his brain, and he never went back to work. And he was a relatively young man. He was only about age 50. And so when I talk to individual patients, I'll ask them, what is your concern? Because I'm much more afraid of the disease than I am of the immunization. And I'll also share that I've been immunized. I couldn't wait. I see a case of shingles probably once a week, and some of it is mild and some of it is very intense and very serious. I've had to give a woman in her 50s 3 months off work in order for her to stay home and care for her mother, who was in her 80s, because her mother couldn't get dressed, couldn't put anything on her skin because her skin was so hypersensitive, it felt like it was burning. So here, this healthy woman in a very busy, high performance job had to take 3 months off work to care for her mother. That's the cost of not being vaccinated. When we talk about cost, going back to that previous question, the caregiving, the disruption of your life, disruption of work, those are serious things. And what we know for older people, living alone, being independent, living in the community, and this is work that Dr. Janet McElvaney was very involved with. Unfortunately, she died recently, but she was doing a lot of research on independence and older people. And what she looked at is she looked at the level of frailty, and shingles often is the tipping point for whether someone can cope with their chronic diseases. Maybe they've had diabetes and COPD, hypertension, but they're living well in the community, they're managing on their own. They get shingles and their life changes. They may never go home again. They may end up in a facility because they can no longer function. So when I talk about vaccine hesitancy, I ask someone, what is your concern? What are you worried about? Because the reality is I'm scared of these diseases. I'm not scared of the vaccines.
Absolutely. It's a great point, Vivien. Thank you. I've got another question here, and I think we've kind of touched on it, but I just want to make sure we've encapsulated it correctly. William, would you like to come forward and ask your question?
Good morning, Dr. Vivien. Your presentation is great, and your practice must be flourishing. I have a question. If you have shingles active, can you still be treated with the vaccine, or is it too late?
So, William, that's a great question. And the American guidelines and the Canadian guidelines are different. The Canadian guidelines say wait 1 year from an active case of shingles and then get immunized. And that's because you've already produced antibodies. You're already fighting off the disease. The vaccine's not going to do that much for you at this point. You might as well wait at least a year and then get vaccinated. So you're preventing another episode, because it's not going to help the episode that's happening right now. The American guideline says, just wait until the lesions are healed. I think that the Americans are a little more aggressive because they don't want to lose people from coming back a year later. And so the American guideline says, if your lesions are healed, then go ahead and take the vaccine. Either way, the vaccine is not going to help the episode that you have at the moment. The vaccine is going to prevent a future episode. And just to be clear, when someone does have shingles, we use antiviral medication right away. There's a number of different medications on the market, and that medication stops the virus from multiplying, so it helps the lesions heal up quicker. What it doesn't do is it doesn't prevent the nerve damage that's already happened. And most of the nerve damage happens before the rash even breaks out. So yes, we use antivirals, but they don't necessarily help that chronic pain syndrome that people get into. And young people, you all know who Justin Bieber is. He's world renowned. He just had Ramsay-Hunt syndrome, and he had to cancel his tour. So young people are all of a sudden aware of shingles. And that's because Ramsay-Hunt has to do with facial paralysis. And that's what Justin Bieber had, because he had a bad episode of shingles and was left with partial facial paralysis. It did resolve and it did heal, but that's the kind of thing that shingles can do. It can damage the nerve so the nerve can't function.
Thank you so much. You're a fount of information.
Thank you.
Thanks, William, for your question, and Vivien for your response. You've touched on it a couple of times now, Vivien, this idea of, shingles is different in a lot of ways. I think there's this kind of element of kind of the lesions, and there's, it's visual, unlike a lot of other diseases. And I think this long-term pain is also a real challenge. I wonder whether you could speak a little bit to the mental health issues that you see as a result of shingles, in addition to just some of the physical health that you're seeing.
Yeah, well, first of all, there's no question when you get sick, it doesn't matter what you get sick with, you feel more fragile. People feel fragile. They're worried that they're going to give it to somebody else. And just to be clear, you can't give shingles to another person. What's in those lesions are chickenpox viruses. So what you would give to somebody else is chickenpox. So if you're with a new baby that hasn't yet been immunized, if you're with someone who's immunocompromised or on chemotherapy, you're not going to give them shingles. You're going to put them at risk for chickenpox. It's not airborne. They have to touch you. But think of if you have shingles on your face and you're holding a baby, your baby could be close to your face. It's possible that you could expose that baby. So we do want to be careful when you have shingles, but it's not contagious giving your partner shingles. Your partner would be at risk for chickenpox if they haven't already had it. When people get sick with something, shingles can be ugly. It can be on your face. It can affect your vision. It can affect your balance and perception. If you get shingles and it affects your ear, people are very unsteady. But the big deal about shingles is it is your immune system that's weaker. And so people feel unwell. They feel like they're fighting a virus. They don't feel good. And even if those blisters heal and the rash is gone, some people are left with fatigue, feeling unwell, feeling more frail. And the drugs don't help, because when we give those pain medications and the antivirals, some people don't feel that well. I noticed that someone was asking about the antivirals. We use them as soon as possible, as soon as the rash breaks out. And that's because they work best at the beginning to stop the virus from multiplying. There's not much point in using them 5 to 7 days after the rash is broken out, because the virus has already done the damage that it's going to do.
Thanks very much, Vivien. See another question here from Francis. Francis, would you like to come forward and ask your question?
Sure. I was just curious, I should know this, but I don't, whether kids are vaccinated against chickenpox, because when I was young, everybody had chickenpox, but I don't know whether that's still true. I mean, kids seem to get vaccinated against most of those infectious diseases now. So I wondered about that.
So Francis, that is a world-class question. That's a great question. Chickenpox vaccine came on the market in 2002. So kids started to get immunized, but it took a while, and not everybody got 2 shots. Some people got 1 shot. So there were a lot of breakthrough cases, even if you got the chickenpox vaccine. What we know now is we think that those people that got 2 shots and mounted a full response won't be at risk for shingles as they get older. But because there were breakthrough cases, and because even with a good vaccine, not everybody chooses to take it, there's lots of people that have slipped through the cracks and didn't get vaccinated. So we can't count on people having been vaccinated, although the bulk of people under age 20 have been vaccinated for chickenpox, at least in Canada and the US.
Thanks very much, Vivien. A question somewhat related to that. If you've been vaccinated for chickenpox, do you still need to get vaccinated for shingles?
Well, Anna, that's what we don't know yet. We don't think so, because you've got chickenpox antibody in your system. You don't have the chickenpox virus or chickenpox antigen in your system. But you may have had a minor breakthrough case between your first shot and your second shot, or you may have had a minor case that your mother didn't recognize. And so we don't yet know whether all of those people that were immunized will be safe not to take the vaccine. It's going to take us another 20 years to make that decision, because we need that age group to get into an older age group before their immune system starts to get weaker. So we won't have a good answer for that for a little while. So the people that make Shingrix can relax. They've got at least 20 years of vaccine that people are going to need. But it may be that we use a lot less of this as that age group that's under 20 gets into their 50s.
Right. Thanks so much, Dr. Vivien. I have a bit of a track change here, but I'm curious, we've certainly seen through our work that, COVID has had some opportunities and some challenges in kind of pushing vaccination forward. And one of it is that it seems to monopolize a lot of the airtime. And as a result, we talk a lot about COVID vaccine, but some of the other vaccines, whether it's influenza, pneumonia, and shingles, have fallen a little bit off the radar. I wonder if you can speak a bit about how can we kind of cut through the noise, and whether you're seeing that echoed in your practice as well.
So Anna, that's a really good question, because everybody is a little tired of COVID and everybody is a little tired of vaccine. Unfortunately, COVID is not tired of us and vaccine is not tired of us, because if you are not vaccinated, you are at risk for these serious diseases. So when a patient comes to me, no matter what they're in for, let's say they're in for their blood pressure and cholesterol medication, I start by looking at their preventions. We know that everybody is behind because we've stopped doing a number of things during the first year or so of COVID. So for women, for example, I'll check, are you due for a mammogram? Have you done your colon cancer screening? Are you due for a pap test? Are you due for bone density? Are you over 65 and we haven't seen how strong your bones are? And where are we with your immunization? What are you due for? And I think it's important to normalize the conversation to say, yes, you're trying to prevent a heart attack by taking your cholesterol medication and your blood pressure medication. I'm trying to prevent what could be a catastrophic disease by screening for cancer and also by updating your preventions. So I look at it as a package. We're updating your preventions. We're screening for cancer. This is what family medicine is all about. And this is what you care about. That's why you're coming to the doctor.
That's great. Thank you so much, Vivien. Just while I have you on that topic, I wonder, how can we as civil society, how can we as individuals be amplifying those efforts of kind of care practitioners such as yourself?
Everybody on this call should talk to their partners, should talk to their relatives, should talk to their families. Are you up to date? Because in general, the population is not up to date. And some of these vaccines are very simple and inexpensive. You know, we're updating tetanus and pertussis. Pertussis is whooping cough. That's really important for pregnant women. That's really important for grandparents if you're going to be around new babies. So we need to be up to date on what we can prevent, because unfortunately, there's so many diseases we can't prevent. We want to keep the budget low, prevent the diseases we can, so that we've got the bandwidth to take care of diseases that we can't prevent.
Thanks so much, Vivien. Got another question here from Brendan Sherlock. We're taking full advantage of your expertise today, Vivien. Brendan, would you like to come forward and ask your question?
Yeah, just to Vivien, is it okay to have a procedure after having shingles, or?
It depends what procedure, and it depends how far from shingles. If you have open lesions, you don't want to do anything, right? Open lesion says you're still at risk and your immune system has not fought that off. If you're a month or two from having had an episode of shingles, then you're home free. You can do what you want.
Thanks very much.
Thank you.
Thanks, Brendan. And another question here from Mark Venning. Mark, would you like to come forward and ask your question?
Very simple. Are there any reactions to getting the shingles shot?
Great question, Mark. Thank you for asking that. Yes, there is. There is an adjuvant or irritant in the shingles vaccine that really stimulates your immune system. Some people are sensitive to that, so you can get a very sore arm. You can get a low-grade fever. You can feel like you've been hit by a truck. And if it happens in the first 24 to 72 hours after the shot. So if I give the shot today, you can feel sick tonight, tomorrow, the next day. If you get sick in 2 weeks, it's COVID. It's not the shingles shot. And so I caution people that about 13% in the study did get reactions to the shot. It's not dangerous. It means your immune system is responding, and it's actually a good sign because your immune system is kicking in. And so the corollary is that some people don't get any side effects and then have called back saying, what's wrong with my immune system? You told me it was a good thing if I get side effects. The answer is we're all different, and some people react more than others. And interestingly, Anna, I'll just share with you, the research suggests that women are more likely to get side effects from a variety of shots, including measles, mumps, and rubella, and some other shots. So women tend to have a more complex immune system that may react to the shots. It's not dangerous. It goes away. And statistically, there was almost nobody that didn't come back for their second shot based on side effects from the first. So people will come back and say, you're right, I feel lousy for a day, but I'm here for my second shot. If you react to the first shot, because it's a 2-shot series, it doesn't mean you will react to the second, and it doesn't mean you won't react to the second. The second shot is quite independent in terms of reactions to the first.
Thanks, Vivien, and thanks, Mark. Super important question. I want to kind of pick up on that question, Mark, and take it in the opposite direction, which is, Vivien, there's oftentimes now, there's some benefits to vaccination outside of just the prevention of a specific disease. We know that certain vaccines now can help with, lower cardiovascular risk and things like that. I wonder if you can speak a little bit about, both for shingles specifically and vaccination broadly, but some of the benefits beyond just prevention of disease for vaccination.
So what you're talking about, Anna, and I think it's particularly important with pneumonia and flu, is what we see is when people are vaccinated for inflammatory respiratory diseases. So that's flu, that's pneumonia, it's going to be RSV. What we see is we see a decreased risk of heart attacks for the next couple of months. We see a decreased risk of other respiratory diseases. Because if you think about it, if someone gets a bad case of pneumonia and has all this inflammation in their chest, it often triggers other diseases. So when we look at vaccine, it's all about keeping you out of the hospital, and it keeps you out of the hospital from other diseases as well. The best research is on pneumonia, on influenza leading to pneumonia, and on pneumonia leading to heart attacks. And that research, a lot of it has been done in Canada and is actually very interesting. When they looked at people in a nursing home and they looked at the group vaccinated compared to the group not vaccinated, the group that was vaccinated had significantly less heart disease, not just less pneumonia.
Wow, very interesting.
With shingles, in my experience, it's not so much that shingles leads to another disease, although it destabilizes diabetes. People with diabetes get infections in those rashes. It's not just simple blisters that get better. But what we know with shingles is the drugs that we use for pain just have all kinds of side effects. And when you're in terrible pain, you're ready to take anything. But the narcotic medications that are really used, and sometimes we're using as many as 4 different medications in a single person, those medications leave you unsteady, affect your balance, give you constipation, nausea, and vomiting. And what happens, and there is research on this, is someone gets up to go to the bathroom, they slip, they fall, they break their hip, they get admitted to hospital for the broken hip. There may not be a mention of the fact that they were on the drugs because they had shingles 2 months earlier. Right? So it's a sequence, it's a downward sequence that happens, and that sequence leads to increasing frailty. And there's different measures for measuring frailty, but very simply, it means not living independently.
And I think, Vivien, you touched on something again that's important, that this idea that I've lost my train of thought. I apologize. You know what? But we've got a great other question from Francis. So I'll have you come forward and ask your question, and I'll try to think on mine again. Francis?
Yes, I was curious as to whether shingles vaccines are something that can be given by a pharmacist. I'm in Ontario, and I'm asking specifically about here, but we know that we've expanded in Ontario what pharmacists can do, and given how many people don't have family doctors in Canada, a big crisis here, I was wondering whether shingles and which other vaccines might be available that way.
So an individual pharmacist has to be trained to vaccinate. So some pharmacists do and some pharmacists don't. But I believe that the regulation suggests that pharmacists can immunize, which is wonderful. There's just a caveat for that, and that is pharmacists don't have access to public health vaccine. And so if you're in the age group where the vaccine is covered by public health, you need to see your family doctor, because the pharmacist would have to charge you for the vaccine because they don't have access to the public health vaccine. That's a barrier that I actually am advocating around and trying to break down, because it doesn't affect this group, but in the school age programs, and particularly with HPV and meningitis vaccine, there was no school in Ontario. There was only virtual school for quite some time. Public health was not going into the school and immunizing the kids in grade 7. So the school-based programs have fallen off dramatically. What we know is pharmacists can immunize, but they can't get a hold of the immunization through public health. So we're trying to break down that barrier so that kids can get immunized, not just by public health and not just by their family doctor, but by any pharmacist that is doing immunization. So it's a long answer to a short question, and that is they're licensed to immunize, but it doesn't mean they can immunize that individual. Depends on their age, their status, and whether or not they qualify for public health vaccine.
Right.
Thanks very much, Francis and Vivien. In terms of, Vivien, you touched on kind of care pathways and pharmacists being in kind of an important part of this. Do you see the expansion of care pathways, or what do you see as the role of expanding care pathways in terms of increasing access?
You know what, Anna, it's all hands on deck. We need everybody. We need the nurses, the nurse practitioners, the pharmacists. In Canada now, dentists are allowed to vaccinate for HPV vaccine because HPV causes oral cancers, and often the dentist is the person that's looking at your mouth and talking to you about it. And so we're expanding the role of who can vaccinate. The biggest problem we have in Canada is that we don't have a national record organization. There's no record keeping on a national basis. So if you get immunized by your pharmacist, your family doctor doesn't know about it. If you
Wow.
get immunized by public health, your family doctor doesn't necessarily know about it. So record keeping in Canada is abysmal. And I would encourage everybody on this call to take a look at the app called Can Immunize. Can Immunize is all one word. It's downloadable for free. It's in French and English, and you can keep track of your immunizations just the way you're keeping track of your COVID immunizations, so you know what you've had. I think that in the future, we're going to see more pharmacists, more dentists, more allied health professionals doing immunization, because there's more immunizations coming, and we need to keep up with that pace.
Perhaps, Luana, we can add that link into the chat for everybody today. I think that would be great.
Yeah, that's some of the work that Immunize Canada has done, and Immunize Canada has been supported by Public Health Canada. It's all about advocacy. And so the area of record keeping is really important. You know, I recently got back from a wonderful conference in Finland for women. And one of the things I learned about Finland is they have one electronic medical record system in the whole country, and pharmacists can access it, patients can access it, doctors can access it. So if you go to the pharmacy on a Friday and you get a vaccine, and then you go to emergency on Saturday and you get stitches for something, and then you see your doctor on Monday, all of that record keeping is in one system. That is not true in Canada or in the US or anywhere else that I know of, other than in some of the Nordic countries. And it's such a shame, because we really do need access to record keeping in order to know what people have had.
Thanks so much, Vivien. The question, my question has finally come back to me, and it was about, you talked a little bit about the idea that people could be hospitalized for something like a fall, and that fall can be kind of tangentially or a product of shingles or the treatment of shingles. What are some strategies in your mind to kind of better capture the impact of shingles and translate that up from a policy perspective?
Yeah, you know, I think that we have to have an understanding that there is not one, shingles is not just a rash, right? So for so long, we think it's just a rash, it's just a couple of blisters, whatever. What's really important is that we understand the impact of the disease. And so when someone is admitted to hospital, what's really important is their primary diagnosis gets noted, but their secondary diagnoses get noted as well. And I think any kind of retirement group, any kind of discussion has to look at what the term is comorbidities, the other things that are going on, because the trigger may have been diabetes out of control. You know, the trigger may have been something else that is being overlooked. And so what happens is a disease like shingles may be underrepresented in terms of the risk of hospitalization, because it's not the primary reason why you're in hospital, but it may be a secondary reason.
Right. Thanks so much, Vivien. I think that's super important. I'm going to get into a bit of a bit of a change track here, but we've talked a lot about pain, and that it really kind of makes shingles or more unique in a lot of ways, this neuralgic pain. I wonder whether you've seen any challenges with addiction in the context of shingles, and whether that's a population that's at increased risk for something like addiction issues.
Anna, it's a good question, but the reality is when someone is in such bad pain from shingles, they are ready to take anything. And as a physician, you're ready to give them anything. You're trying to prevent the side effects of the drugs, but addiction is low on the list. I think it may be significant in a younger population, but in an older population, most people want to get off the pain drugs as quickly as they can, because there's so many side effects and people don't feel well on these drugs. It's not like they're getting a high on morphine. They're really feeling, you know, nausea, vomiting from the levels of codeine that they're taking. So I haven't in my practice seen an issue with addiction, but chronic pain is debilitating. People lose their livelihood if they're younger and they're working. People often lose their social network because they don't go out for 3 to 6 months. You know, they can be quite miserable. So I think that the problem is really how to manage that pain. And we're managing it now with some different drugs, some neuromodulating drugs. And I'll use, you may be familiar with a drug like gabalin or pregabalin. Their trade names are gabapentin or Lyrica. We're trying to avoid some of the narcotics and use some of the nerve modulating medications. But basically with severe shingles pain, you'll use anything.
Yeah, absolutely. Thanks, Vivien. I see some heads nodding and some fingers pointing, so I think it resonates with certainly a few people in the crowd that might have had shingles. So really, really important. Vivien, I want to ask a little bit about, you've been a wealth of information. Any other resources that you would recommend kind of directing people to kind of learn more about this issue, but maybe about healthy aging more broadly as well?
So thanks for the question, Anna. Certainly Immunize Canada is a great resource to go to, and I see Luana put that in the chat. I want to share with you that I wrote a book. I'm going to hold it up so that maybe you could see it. I don't know how well this shows, but it's called A Woman's Guide to Healthy Aging. It's easy to read. It's on Amazon. And I do have a complete chapter on immunization. I also have a website, and in my website, I've got some podcasts and some immunization information and some of access to some of the talks that I've given before. I think the more educated you are, the more you understand, the better you do. And this audience is old enough that you'll remember an ad on TV for Clairol. And that Clairol ad came on, and it was like, she told somebody, and she told a friend, and she told a friend, and all of a sudden, the whole screen was filled up with pictures of people. Your job, if you've learned something this morning and you got up early to be online with me, your job is to share the information with your family and your friends, because no matter who you look at, there are lots and lots of people that have not taken immunization that should be immunized. And I think this is the best work we do in family medicine. You know, it's one thing, I'll use heart attacks as the example. You know, you try to get someone to watch their cholesterol and quit smoking. Once they have a heart attack, they'll do anything, right? They've already had their heart attack. They want to be careful. Immunization is all about getting aggressive before something happens, not after something happens. And that's why it works so well. And that's why I think it's so important.
Thanks so much, Vivien. I'm going to come to our next speaker briefly for next week and give you some time to kind of collect some closing remarks for us. But in the meantime, Luana, would you mind throwing up our tile for next week's cafe? Fantastic. Thanks so much, Luana. So next week, we have the pleasure of being joined by Professor Jean-Pierre Michel on the evolution of geriatrics and the future of healthy aging. So it'll be another fantastic session, and we look forward to having you all join us. In the meantime, we've had such a fantastic discussion today with you, Vivien, but I really want to give you the final minutes on the floor and tell us kind of what, if we had to take home 3 kind of key messages today about shingles and the importance of vaccination for older adults, what would they be?
I think number 1 is review with your physician all your preventions. It's not just shingles, although obviously it's important. It's the other vaccines as well. It's screening for the appropriate cancers. It's screening your blood pressure, your cholesterol. It's important to do that kind of screening. We want to prevent disease, not just treat disease. And by the time you have symptoms, by the time you feel unwell, by the time you're not yourself, it's already later in the course of what we can do in medicine. So number 1 is take charge and be sure that all your preventions are up to date. Number 2, exactly what you're doing now. Keep on learning and keep on having social networks, because I think that's really important for healthy aging overall. And my own feeling is that the networking and socialization, even on Zoom, even when it's not in person, is helpful in terms of cognition, is helpful in terms of brain health. So think about what we've said today. If you have a chance to get the book, read over the chapters, see if we covered everything that we should have. This is a learning opportunity. And my final thing would be open to vaccine, because there's more coming down the pipeline. And just the way people in the early 50s were afraid of polio vaccine, and now we take it, we don't even think about it. Don't be afraid of the vaccines that are coming. They're well researched. The work that's going on with these mRNA vaccines is absolutely fascinating and really Nobel Prize quality work. And we're doing so well as a society because we've learned so much. So be open to what's coming. Get your flu shot. It keeps you out of hospital, even if you get the flu.
Thank you. So I'm not even going to add anything more. I just want to thank you, Vivien, for your time, and thank you everybody for joining us today. It was an absolute pleasure. Have a great weekend and we'll see you next
Thank
Friday.
you. Very
Thank-
nice to meet everybody. And I like the fact that I could see some of your faces and that you participated with me. It makes it real for me too. Thank you
Terrific.
so much. Thank you, Anna. Thank you, Luana. All the best to everybody.
Thanks so much, everybody.